Y'all are a lot easier than the Senate. We don't shut up for anybody. Did all our first panel stay? Dr. Petzel still? Good. Thank you for staying. Let me break before I introduce our second panel. We have some distinguished. I'm sorry. We have some can you hear now? Distinguished guests in the room. I apologize. Mike Glanton, Representative Mike Glanton from the Georgia Legislature. Hold your applause a minute, but I do want you to applause. John Yates. John's the oldest living veteran. He and I served together back in the 80s, and he's done a wonderful job for years and years and years in the Georgia Legislature. And a dear friend of mine, Alex Hill, was my fraternity brother in college. His son, Hunter Hill, is a state senator and a captain who served 2 tours in Afghanistan. So give them a round of applause. Thank you for being here. And Mike's daughter is serving on active duty with the United States Army today. Is that correct, Mike? Thank you for your service. And you made a great speech on the floor of the Senate when she deployed, if I remember correctly. Caught it on TV. We are really fortunate to have a great second panel, and I think you're going to learn an awful lot. And I think our members from the VA and the IG's office are going to learn a lot too. First is Major General Jim Butterworth, who's the Adjutant General of the Georgia National Guard, and as one who was a guardsman back a long time ago, I'm very proud of the job he's done at the Georgia Guard. And I think when you hear his testimony, you'll understand how important the Guard is and the burden that the Guard shares with the Veterans Administration in dealing with soldiers with PTSD, TBI, sexual harassment, drug problems, and all those types of things. And your testimony is tremendous. I can't wait for everybody to hear it. Vondell Brown has already been quoted by me 2 or 3 times, and I told him he had to repeat all the quotes because I might have gotten them wrong. But he's with the Wounded Warrior Project, which is a tremendous project and service to our veterans. And Vondell, we're delighted to have you here today. Susan Johnson, the Director of Brain Injury Services at Shepherd Spinal Center, is here. And where is James? There's James Shepherd, part of the Shepherd family that provided our state with one of the great resources that it has in terms of the Shepherd Spinal Center, that provides tremendous services to veterans. In fact, Mike Reynolds is one I just mentioned at this hearing, who's a man I met at Shepherd Spinal Center who was profoundly injured in Afghanistan and misdiagnosed on the field, and his delay in getting treatment caused him severe problems, if I remember. And Shepherd embraced his problems and voluntarily helped him come back to a reasonable state, given his state of life. Oh, I thought that was for me. Okay. And thanks for what Shepherd Spinal Center does. Peachford is here today. The Peachford Hospital is a direct provider to the Atlanta VA. You heard Dr. Petzel refer to Peachford. And their director, Rebecca Hayes, is here as the Director of Nursing and Clinical Services, and we appreciate you being here. Peachford is a phenomenal facility. I've known people who've gotten tremendous help at Peachford. You do a great job. And Dr. Ryan Brashear is the Director of Psychological Services for Wellstar Medical Group, which is my hometown medical group in Marietta, Georgia, and do a significant amount of work in suicide prevention and have worked a lot, I think, with veterans research on some of the problems we've talked about today, and your testimony will be welcome as well. Yes, so we'll start up to 5 minutes, if you can hold it to around 5 minutes, but I don't give generals orders, so you take whatever time you need. General Butterworth, why don't you be first?
Thank you, sir. Good morning. I certainly appreciate the opportunity to be here, and look forward to the conversation and commend you on the vision for having this discussion. Senator Isakson, thank you for inviting the Georgia National Guard to testify as part of this hearing to ensure our veterans are receiving the mental health care they deserve. Unfortunately, suicide is a real and ongoing tragedy within our military family. Over the last decade, within the ranks of the Georgia National Guard alone, we have had 18 suicides. Since January 2012, throughout the entire National Guard, there have been 207 suicides. Of those, 4 were Georgia National Guard members. Within the last month, we have had 1 suicide attempt and 6 other Guard members who have reported suicidal ideations. Most cases of suicide, attempted suicide, and suicidal ideation within the Georgia National Guard appear to have been related to finances or personal relationships issues, which you alluded to earlier. The Georgia National Guard is working to mitigate suicide by focusing on prevention and intervention. Both Army and Air National Guard suicide prevention programs have a focus on resilience training provided by the active component Army and Air Force. Although the Army and Air Force resilience programs differ slightly in application, both teach life skills to increase mental strength of our service members. These programs consist of a positive psychological model program based on 5 pillars: physical, social, emotional, family, and spiritual. Resilience training is conducted annually through unit training sessions and online web-based training. Our suicide intervention programs focus on both peer and leader involvement in ensuring the well-being of our team. Our intervention programs consist of methods and training to teach our service members to identify and intervene with someone who is having thoughts of suicide. Behavioral health is a basic component of force sustainment for the Georgia National Guard. Psychological and emotional health could preclude a guardsman from deploying and threatens homeland defense capabilities. In other words, this is a readiness issue. Members of the military and their families are part of a unique mission. They speak their own language, and they have an increased likelihood of experiencing certain behavioral health conditions such as PTSD and TBI, as you have already alluded to. Untreated behavioral health can increase destructive, high-risk behaviors, including suicide. The Georgia National Guard cannot provide behavioral health treatment to service members or their families beyond assessment, brief counseling, intervention, and referral. Therefore, our goal is to identify service members at risk for suicide and other behavioral health disorders and then refer them for treatment, whether that is to the Department of Veterans Affairs or to the community healthcare professionals. Both of those things you have alluded to as well. To address the growing behavioral health needs of our citizens in Georgia, and Senator, I would submit that this is one of the core benefits that the National Guard can do as a state-based organization. The Georgia National Guard has proactively developed comprehensive case management programs with state and community partners. I'd like to take a moment to highlight 3 of these efforts. The first effort, which is already implemented, are mobile crisis teams, which are a collaboration within the Georgia Department of Behavioral Health and Developmental Disabilities. We've worked on this program in concert with the governor, and they respond to at-risk service members. These teams provide assessments, referrals to providers, and follow-up contact post-crisis within 24 hours. I would respectfully submit not 14 days. Additionally, we have 2 new innovative programs that are scheduled to begin this fall. The Behavioral Health Clinical Case Management Program is a contracted program that provides a full range of behavioral health care services provided by licensed clinicians to assist service members through the full continuum of care, which most notably includes follow-up with service members and providers to monitor treatment progress and then reevaluate the service members so that they can return to duty. Georgia National Guard has also collaborated within the Georgia Department of Behavioral Health and Developmental Disabilities, Emory University, the Military Family Research Institute at Purdue University, the National Guard Bureau's Psychological Health Program, and the Center for Deployment Psychology to create the STAR Behavioral Health Providers. STAR Behavioral Health Providers is a registry for service members, families, military providers, and administrators to locate civilian behavioral health professionals with specialized training in understanding and treating military service members and their families. The suicide prevention, intervention, and behavioral health programs that I've just mentioned outline and address our Guard members that currently serve. But when National Guard members leave our ranks, there are often limited resources available to support them. The Department of Veterans Affairs is the primary agency to assist our service members medically as they leave the organization. The first challenge of every service member, especially National Guard members and reservists, is eligibility of VA medical benefits. Traditional National Guard members, generally, those are more directly referred to as part-timers, generally do not meet basic eligibility criteria to receive VA treatment. If a National Guard member does meet the criteria, their injuries or medical conditions must be service-related in order for the VA to provide treatment. Upon eligibility verification, our currently serving and former Guard members can be referred to the VA for treatment. You have already heard today many of the challenges that service members face at the VA. To minimize or mitigate service issues between our Guard members and the VA, we have been working to incorporate programs, as I have alluded to, such as the Behavioral Health Clinical Case Management Program explained. These contracted case managers will assist with the referrals and service members and help them navigate the VA and the administrative process. As the close of Operation Enduring Freedom is upon us, so too is the challenge of funding programs such as these that we've mentioned. Many of our Guard member and family services that we enjoy today did not exist a decade ago. As our National Guard was mobilized for Operations Iraqi Freedom and Enduring Freedom, along too came funding to support the health and well-being of our Guard members and their families. In the near future, and I refer directly to the OCO funds that Congress is deliberating on, with drawdown and reduction of overall forces, funding to provide behavioral health assistance to our service members may be in jeopardy. In closing, sir, as President Calvin Coolidge once said, the nation which forgets its defenders will soon itself be forgotten. Understanding that, the Georgia National Guard is grateful to this committee and you, Senator Isakson, for its continued support of our Guards members and their families. Your support is evidenced here today by the invitation for me to be here to represent the Georgia National Guard on this critically important issue. I thank you very much for the opportunity to be here today.
Thank you, General.
Yes, sir. Thank you.
Ms. Brown?
Chairman Isakson and members of the committee, thank you for inviting me to testify today on this important work with this committee in doing to help veterans from Iraq and Afghanistan who are struggling with the psychological wounds of war. I'm a career Army veteran and a wounded warrior who has been treated at VA facilities to include the Atlanta VA. Now, as the Atlanta Alumni Manager for the Wounded Warrior Project, I am honored to work daily with wounded warriors, many of whom have been patients at the Atlanta VA. I've struggled with PTSD as well as residuals of traumatic brain injury from several IED blasts in Iraq. As a Warrior Transition Battalion First Sergeant at Fort Stewart, Georgia, and in my current work with the Wounded Warrior Project, I've seen families and lives ripped apart and ended when mental health care has been inaccessible or not appropriate. As I explained in my full statement, sir, I'm one of many warriors who suffered along with psychological wounds and for too long did not ask for help. But the rising suicide rate certainly suggests a need for real focus on those who deployed to Afghanistan and Iraq and who are not seeking help today. I see this as a bigger challenge for the VA, which they can't handle alone. Mr. Chairman, Wounded Warrior and Wounded Warrior Project agrees with you that the community partners should make a real difference. Veterans who do seek VA care for war-related mental health problems have benefited from this committee's oversight and legislative work. For example, your focus on unreasonable waiting times for needed mental health care led to VA to increase its mental health staffing. Nevertheless, my teammates at Wounded Warrior Project and I still see gaps in VA's efforts to provide mental health care, gaps that are also evidenced at the Atlanta VA. I do want to acknowledge Director Wiggins' efforts to improve mental health care in Atlanta, but believe that there is still a long way to go. What I often hear from warriors is difficulty getting appointments when they need them, being handed from one mental health provider to another, difficulty in developing rapport with providers, and of being offered medication to ease symptoms rather than getting talk therapy that might help resolve deeper problems. There is group therapy, but it often takes a long time in individual therapy before a warrior with PTSD is really ready for such a therapy as group. So medication seems often the only thing being provided, and as I explained in my full statement, sir, I've personally witnessed the tragedy of one of my own soldiers' struggles with PTSD and misusing medication that took his own life. My full statement also offers a few examples of some problems that I think still need attention at the Atlanta VA. What I'd like to really emphasize, though, from my personal experience is that providing effective mental health care requires building a relationship of trust between the provider and the patient. Too often, that is not what our warriors experience at the Atlanta VA. To illustrate, one veteran reported that within a 3.5-year period, he was seen at VA by 3 different psychologists, as well as different psychiatrists and social workers. He told me that having to retell the difficult war zone experience to a total stranger each time actually worsened his symptoms. It does not only take time, but some expression of caring to win a warrior's trust. This is particularly true for those with PTSD. Rudeness, insensitivity, and disrespect, whether from a clerk or a clinician, will not build trust. Let me give you an example. A veteran with PTSD who was seen for the first time just less than a month ago by a mental health provider at the Atlanta VA said he felt that the provider just wanted to get rid of him. The warrior told me that the provider never introduced himself, didn't try to build any kind of relationship, and when the warrior broke down during the meeting, he was not even offered tissue or showed no empathy. The veteran left feeling more depressed and broken than before. Understandably, this kind of experience will cause a veteran to lose hope and confidence in the mental health care. Yet it is altogether different from the empathetic care I personally received from as a polytrauma patient in Washington, D.C. less than a year ago. With warriors still waiting too long between appointments and seldom getting individual therapy, I would like to think that the Atlanta VA still needs additional mental health staff. But the goal can't just be to get a certain staffing number. The goal has to be to provide timely, effective mental health care. To be effective, care has to mean more than simply providing medication to a warrior struggling with PTSD. I think it has to start with establishing a relationship between trust with the provider and the warrior. That can't be accomplished where there's frequent turnover or no continuity. I think clinicians also have to have experience with PTSD, have to understand military culture and combat experience, have to communicate empathetically, or have to be given the opportunity to exercise good clinical judgment. But effective mental health care is not only about clinicians. It is also about instilling a culture of good customer service and accountability throughout the entire facility. Without that, no institution can thrive or provide good care. I understand that VA leaders here and in Washington have been working to make improvements, but I think there are much more to be done here in Atlanta and nationally to close the gaps in VA's mental health system. I do know that Wounded Warrior Project is eager to work with the committee and with VA to help in that important work. I'd be happy to answer any questions you may have, sir.
Your reaction to Vondell is exactly the reaction I had when I got his testimony. I stood up and clapped, and I was the only person in the room. You know, all of us on these panels are important. You got a general sitting to your right, a pretty lady sitting to your left, but nobody here is more important than you because you've been there, you've experienced it, and I think your testimony ought to be required reading at the entire Division of Health at the VA because in a succinct way, in a meaningful way, and a way of actual experience, you've told the story of the American veteran that has challenges with mental health, PTSD, and TBI. Your testimony today is not just a service to this committee or to those that will watch these proceedings, but I'm going to make sure it's a service to the Veterans Administration so they respond to the type of advice that you're giving them in a non-critical, very compassionate, very compelling, very personal experience way. Your testimony is a tremendous value to the United States military, to the Veterans Administration, and to all of us here personally. Thank you very much.
Thank you, sir.
Ms. Johnson?
Senator Isakson, thank you for this opportunity for Shepherd Center to talk to you a little bit about some of the challenges that we've experienced with veterans and even other military service members. I'm speaking on behalf of the Shepherd Center Share Military Initiative, and this initiative started in 2008 as a result of a collaborative partnership between a philanthropist, Bernie Marcus, Shepherd Center, who has expertise in TBI and spinal cord, and the TRICARE South military healthcare insurance. And as a result of that, what we looked at is really trying to provide those services and fill some of those gaps for those veterans who came back and needed additional services or fill in those gaps for some of the signature wound that we found with TBI and PTSD from these wars. As a result, we initially started out serving moderate to severe TBI and SCI, and what we found is the VA's polytraumas do an excellent job. Where we found the gaps and where we really put our emphasis is in the mild TBI, PTSD, where they were looking at trying to ramp up for meeting some of those needs. As a result, we see many of those chronic individuals who have TBI, PTSD, and significant other healthcare mental health issues resulting in chronic substance abuse, suicidal and homicidal ideations. And so we do see many of those folks 4 and 5 years post-injury who did not succeed in other programs or did not have access to other programs and or were not meeting the needs in the VA system. We serve these individuals for about 3 months in an intensive program. It includes medical personnel as well as psychologists, psychiatrists, and social workers. We have a case management system that has 1 to 6. It has 6 patients because these are very complex issues that they have to navigate those systems through. We actually also provide a significant transition program, where we find that while we'll do a great job in our program and services in a facility, where the issue tends to lie is meeting the needs of that transition back into their community, back to the systems and the VA systems as well. And we support these individuals in their med board process, in navigating the VA systems and understanding what their benefits are, because most of these individuals do not understand. So I was pleased to hear that the Atlanta VA is looking at ramping up their case management services because we do feel that those are where a good bit of gaps are at this point in time. We've served over 400 military TBI, SCI, and TBI PTSD patients, and we have had no suicide or homicides in our program. And we continue to follow and monitor those folks for up to a year because we find that transition goes up and down, and that helps support those people through those systems. Some of the opportunities I think that I want to talk a little bit about that I would like to offer to the Atlanta VA is a couple of things. But before I mention that, I do want to talk a little bit about that. When we first started the program, the Atlanta VA was very supportive of Shepherd Center and their initiatives. The Atlanta VA director at that time toured, as well as their regional director, and just even wrote letters of support. They set up meetings with their staff so that we could set up a collaborative relationship to better understand where we had the gaps in services and what we could offer these veterans. Because we're just a small program. That program only serves about 35 a year in the mild TBI PTSD. So we were here to help fill those gaps. Thank you to our philanthropists who we do raise a lot of money to support that. However, we really never were able to connect. We met with their trauma case managers, their social workers. They came to visit, but we weren't able to connect and really get a better understanding of how some of their veterans could benefit from our program. So we established a relationship with the psychiatric department that dealt with PTSD, and we started seeing a lot of referrals because what they realized is that PTSD wasn't the only overriding problem they were dealing with, it was also TBI. And they understood that these folks needed a comprehensive program 7 days a week to help support those life skills and needs for these individuals. However, those referrals stopped, and we were told that it was as a result of certain people had to approve that before they could come in. So most of our referrals have been from word of mouth, or those veterans, the Wounded Warrior Project, a couple other family support initiatives that have given us the referrals for these folks. So basically, in our work with, actually, we've had over 40 Atlanta VA veterans who have been a part of our program. And part of that, we've learned a lot. And we learned a lot, too, when we were starting the program. So by no means are we here to say we're the experts, and we're the experts in the beginning. We learned a lot as well. And as a result, we do have a dedicated team, and a dedicated team who develops those relationships, who helps coordinate the care, who makes sure that they get the timeliness of care that they need. But some of the issues that I think that we saw as a result in working with the Atlanta VA or those veterans who were at the VA was the backlog of claims, resulting in long waits for even initiating or getting services. And I think that's been talked about at length. So certainly the opportunity is really to have some benchmarks that really support these folks getting in a timely fashion. Because for those people who don't know, if they don't have a claim and the claim isn't initiated, then they don't get the service through the VA. And so thus the long among issues, and especially with our folks who have the dual diagnoses of TBI and PTSD. They don't remember, they may miss an appointment, and they may not have that coordination that they need or that hand-holding that they may need. And certainly 150 150 patients to one with this complexity of issue, I might think you might want to look at that for looking at your higher risk folks. Another area for opportunity that we thought that would be good is to look at the establishing in the VA system for appointments and care needs, especially with multiple issues, TBI, PTSD, pain, sleep, follow-up care, etc. For instance, we had a veteran, and just recently, and this was in the last 4 months, it took one veteran 4 months to get an appointment with a primary care physician. Once the physician assessed that veteran, they recommended that they go to the trauma program because she had suicidal ideations. As of now, the individual has not had any follow-up call. They did have a follow-up call just yesterday or a couple of days ago that said, we got a message that your doctor made a referral and we want you to come to the PTSD clinic and get tested to determine a need. And this is an individual we've had to bring back into the program to help support because of the issues that she is currently having. I think a solution obviously is to have that relationship or have a case management system that develops that relationship, because we do find that these folks are not trusting. And that is just a result of uncoordinated care. So having a system that helps monitor and follow up, because we do find our military transition coordinators here today with us actually follows up on a regular basis. And they don't often tell you that they're having the issue. You really have to do a lot of engagement to really understand that. Another area of importance is really looking at coordination of care and having accountability standards. I would assume that if, in fact, case management is following up on these patients with a regular basis, that maybe there be some sort of outcome or documentation to understand and support to figure out, and somebody really reflecting on, are there really issues that we need to take care of? So having accountability measures, which we actually have in documentation that appears to work, we actually goes back to the treatment team to see if there are other things that potentially this client might need. Also, good to hear about the electronic medical record. I think the issue here is that we have every veteran that we've ever dealt with has been a significant delay in getting records and or getting appointments because they have lost the records. So that might be something that could be looked at. And one last thing that I really feel very strongly about is really having and developing a collaborative partnership. I have felt this sort of frustration between them and us in regards to what we do. And so I would like to be able to offer that we only serve one small, minute population, and we can help deliver that service. Shepherd Center sees over 2,000 people a year. So we're really good at what we do. And I wondered if we could have a better collaborative relationship and really understanding what's working and what's not working, and really spend some time in managing these patients and families. Since you've asked us to speak, we've been asked to sit on their advisory board, which is a really good first step, as well as being a partner in a conference they're having on collaborative partnerships. So I thank you for having this opportunity to bring to light some of the issues that I think are really important to serve our veterans. And I do feel the Atlanta VA does want to serve their veterans. I just think it needs to get down and really pay attention to the people who are actually delivering the service. And there are many good people. We have met many good people who want to do that. I'm just not sure if there's some issues on coordination and breakdown. Thank you.
Thank you very much. Dr. Bashir?
Senator, it's a privilege to be here with you today. My testimony is an extension of my status, first as a concerned citizen of this country, secondly as a Georgian, and thirdly as a professional who's invested a number of hours studying the problem of suicide, not just amongst veterans, but as an issue that transcends that distinguished status. Before I proceed, I'd be remiss to overlook or fail to acknowledge the veterans that are in our presence who've invested in us. Thank you for your service, Mr. Brown. Thank you. I intend that sincerely.
Be sure and speak right into the mic so they can hear you. There's people in the back going like,
sure. I'm a psychologist and a researcher who's had the good fortune of collaborating with VA researchers and clinicians for the past 6 years. Prior to my role as the Director of Psychology with Wellstar Health System, I was a fellow and a researcher with the VISN 19 Mental Illness Research, Education, and Clinical Center, or MIREC, in Denver, Colorado. That's a group of exceptionally bright and impassioned colleagues who are committed to conducting clinical and translational research pertaining to veterans and suicide. It's outside of my discussion today to review the many factors pertaining to suicide in veterans. Rather, it's my hope that by reviewing the processes we've implemented at Wellstar, which is a 5-hospital system in Metro Atlanta, that I might be able to describe how a systematic effort implemented with buy-in from our leadership has helped to provide some safeguards regarding the management of higher risk patients who present to our emergency departments. In my estimation, anyone involved in suicide prevention work at a system level should be aware of 2 fundamental principles. The first of those is this. Clinical policies and procedures, in other words, what clinicians actually do in practice, must exist as an extension of core organizational values, and these values must be championed by clinical leaders. It's been my experience that when organizational values and clinical practice are disparate, suicide prevention strategies often fall short. Effective execution requires leadership buy-in, thoughtful planning, consistency, and reassessment. Without any of those aspects, the best practices fall short. 3 years ago at Wellstar, we implemented and engaged in a 3-step plan to introduce best practices regarding suicide prevention to our system. In phase 1, we provided training and education to all of our mental health emergency room assessors. We introduced them to the work of Dr. Thomas Joyner, who's a professor and renowned suicidologist at Florida State University. We also introduced them to the self-directed violence classification system, which is a nomenclature for suicide and related behaviors that was developed collaboratively by the CDC and VISN 19 researchers. In phase 2, we taught our assessors how to use Stanley and Brown's safety planning work. Those good folks are up at Columbia. Safety planning is not telling a patient what not to do. There's no compelling science or evidence to suggest that those strategies actually work. Rather, it's helping people learn what to do in the event that a crisis presents in the future. I think it's important that we remember this maxim: people only do what they know how to do. Safety planning is a collaborative process in which patients and providers sit down together. We craft a plan of how to keep a patient safe as an individual. It's an individualized plan. It's not handing someone a piece of paper asking them to complete it independent. It's intended as an intervention, and it can be a powerful one. In phase 3 of our implementation process, we began having patients with behavioral health needs in our emergency rooms complete the habituation and acute risk measure, the HARM. The HARM is a theoretically derived, valid, multi-factor measure that addresses acute agitation and suicidal intent. We included the HARM in our implementation efforts for one simple reason: patients consistently outpredict providers when it comes to their own suicide intent. And I think that's very important. Sometimes as providers, we assume that we've got it figured out. The reality is the person who best knows is the patient, the veteran, the client. The second principle that I wanted to note is related to suicide prevention at a system level is this: without continued commitment, suicide prevention is difficult. Commitment is absolutely critical. Recently, I sat with a patient in a psychotherapy session. The patient had contemplated suicide the day before. That contemplation involved a plan. We're nearing the end of the session. I have a patient in the waiting room. I'm back to back throughout the rest of the day. This is not an uncommon problem in the VA, outside the VA, in primary care, in mental health. It doesn't matter. It's quite common. So the question is really, do we rush to the next session to keep from inconveniencing the next few patients? It might not be practical to run 20 minutes past the hour, but decision-making ultimately comes down to a choice. It's a choice between prudential factors, what is practical, hedonic factors, what feels good or doesn't feel good, and ethical factors, what the right thing to do is. In this case, the ethical option is the only one that would mitigate risk, and it's the only one that was correct. So we developed collaboratively a safety plan. I want to note that many of the best practices that we developed at Wellstar, or that we implement at Wellstar, were not developed by us. They're actually developed by VA researchers. and I have tremendous respect for what the VA is doing. The VA has responded to the 2008 recommendation of the Blue Ribbon Panel for the development of a uniform nomenclature. That's the system that I referred to earlier. The Veterans National Suicide Hotline was developed. Safety planning has been implemented. Suicide prevention coordinators have been hired, and recently a VA clinician consultation service was announced to help providers manage high-risk veterans. This is an innovative program. I just learned about it myself. It gives VA clinicians the opportunity to call experienced suicidologists to help manage high-risk patients. It's a phenomenal program. I applaud all of those efforts and implore the Atlanta VA to utilize and promote these various resources. With continued champions in your leadership, you have the opportunity to really model for us how to treat patients with dignity, respect, and how to implement best practices. Thank you.
Thank you very much. Ms. Hayes?
Thank you, Senator. Thank you for the opportunity to appear here today and provide this testimony. Peachford Hospital is honored to partner with the VA Atlanta to provide mental health treatment to those who have served our country. Peachford entered into a partnership with the VA Atlanta more than 4 years ago to provide mental health treatment to veterans who needed inpatient care but were unable to receive care at the VA because of bed capacity available. Several best practices have been identified that have improved the experience for the veteran being served at Peachford and communication with the VA staff. A core team from both the VA and Peachford leadership was established to solidify communication from both parties to ensure the needs of the veteran are met. This team meets monthly and maintains an action plan to address issues as they arise. Veterans are referred to Peachford Hospital via the psychiatric emergency room at the VA Atlanta. Following an evaluation, a physician-to-physician review is conducted with each referral. Veterans who are on the high-risk protocol at the VA are identified and communicated to the treatment team at Peachford to ensure that appropriate measures are taken to identify risk associated with discharge, such as access to weapons and frequency of aftercare appointments. Turnaround time for the referral process is anywhere from 15 minutes to an hour and a half, depending on the complexity of the case. Throughout this relationship, peer-to-peer department head communication has addressed issues concerning veterans as they arise. These issues include patient complaint resolution, utilization review, discharge planning, medical treatments, and housing issues. Peachford doctors use the VA formulary for prescribing medications to ensure access to these medications once the veteran is discharged. A Peachford courier picks up the medications from the VA pharmacy, and the Peachford pharmacist reviews these medications with the patient upon discharge from the hospital. This ensures that the patient leaves the hospital with a needed supply of medication. The use of clinical liaisons embedded at Peachford Hospital from the VA has improved the veteran experience and treatment by bridging the gap between treatment at the VA and treatment at Peachford. These licensed counselors and TED treatment team are active in the planning and discharge planning of each veteran. The liaisons can provide information to Peachford regarding past treatment history if the patient is unable to do so. The liaison obtains the necessary appointments for veterans and can access services at the VA that civilian providers cannot access. Peachford has received several environment of care inspections from the VA staff trained in this area. This ensures that veterans receive care in an environment that meets safety standards established by the Veterans Administration. Once a veteran is discharged from Peachford, a packet of information is sent to the VA provider as a handoff of communication between the care providers. Several challenges have been identified during this relationship. These include homelessness. A high number of veterans served at Peachford are homeless. This creates a barrier in discharge planning, requiring the use of a homeless shelter and contributes to the recidivism of the veteran. Many of the veterans served at Peachford have a comorbid substance abuse dependence diagnosis. This can contribute to a longer length of stay in the hospital and create challenges with appropriate follow-up care within the VA system, for example, available space within the substance abuse treatment program. When a veteran at Peachford requires a medical test, such as an MRI or CT scan, the Peachford physician is unable to order the test directly from the VA. This can cause a delay in treatment while the Peachford treatment team is navigating the VA system to reach the appropriate team to request the test. Peachford has identified several recommendations to improve the psychiatric and substance abuse treatment for veterans by civilian providers. Expansion of the clinical liaison role to include all veterans served, not just the ones referred from the VA, would enable Peachford physicians to make referrals into the VA programs without a veteran having to walk into an evaluation for possible inclusion to a program. Having a solid discharge plan that a patient can start right away increases the likelihood of compliance with the plan and decreases recidivism. Increasing the availability of services to veterans as a step down from an inpatient setting and improve the likelihood that a veteran can maintain a stable baseline or maintain sobriety. Expanding the continuum of care should include, but not limited to, a partial hospitalization program, treatment that is offered 7 days a week for 6 hours a day, treats patients with psychiatric and substance abuse issues, and seen by a physician twice a week or more if needed. Following the program day, the patient returns home to family, if applicable, or a residential setting such as a halfway house or group home. Family involvement is encouraged to improve support of the patient. Intensive outpatient treatment is offered 3 or more times per week for 3 hours per day. This option is often used as a step down for partial hospitalization or with patients who have jobs and do not want to miss work. Lodging is a temporary housing solution while patients are in treatment in one of the outpatient programs at Peachford. Patients are transported daily to treatment and provided 3 meals per day. Many patients choose this option if transportation to treatment is an issue or if driving distance is too far to travel on a daily basis. Patients are assisted with making arrangements for housing if needed at the end of treatment. Thank you so much for the opportunity to come here today.
Well, thank you, Ms. Hayes. And I'll ask you the first question. The clinical liaisons, are those VA employees that work with you on the casework?
Yes,
How
sir.
long have they had clinical liaisons, to your recollection?
Pardon?
How long have they had clinical liaisons with Peachford?
We have had them for a couple months.
So that's just started?
Just started.
Dr. Petzel, is that a product of your initiatives to react to the IG's report?
That's a product of Leslie Wiggins' initiatives, yes, to adopt to the report.
That's one of the, and your testimony about how effective that's been demonstrates, as bad as the circumstances were that caused this investigation, we're learning a lot of good things to help our veterans, and I appreciate that. Dr. Brashear, you talked about your work in Colorado with the Veterans Administration.
Yes, sir.
And you commented on the quality of research that they do.
Absolutely.
Are they applying all the things they're learning from their research within the VA system as well as they should?
With respect to Colorado or with respect
to the entire VA system?
Implementation's very, very problematic. A good example of that would be the self-directed violence classification system. I mentioned earlier in the testimony that was developed by VISN 19 and CDC as a collaborative. VA announced the uniform adoption of the nomenclature. That was, I believe, in 2010. I'd have to go back and look. In the few years since then, implementation has varied hospital to hospital, outpatient clinic to outpatient clinic. So although it's been the mandate has occurred, implementation of that system varies considerably.
Well, this is a reoccurring theme of today's hearing where we have isolated successes that aren't shared within the same system. My father used to always tell me when I was complaining about my economic status, he'd say, "You're sitting on a ham sandwich starving to death." And what he was trying to talk about, if I'd get off my seat and go out and work, I could probably make some money. Well, I think sometimes if you just look inside at what your own operation is doing, like we talked about Charlie Norwood VA and the Atlanta VA, there are a lot of situations that can be applied. So I hope one byproduct of this will be some idea sharing mechanism within the VA where they can replicate best practices, because if it works in Denver, it'll work in Atlanta, or vice versa. But if there's a wall or a barrier there, it's no good. Ms. Johnson, you said originally, or didn't say originally, but you said for a period of time you had a good communication relationship with the VA, Atlanta VA, and then it kind of dropped off. Is that correct?
Correct.
Now they've come back and asked you to be a part of an advisory board, is that right?
Correct.
When you had me out about a year ago, when Mike Reynolds was there to visit that group of veterans, they had come to you because they lost hope or lost help at the VA, is that right?
Correct.
And you provided that service to them for whatever they could afford or whatever coverage they had, or if they didn't have any, you provided that service to them as a center, right?
Correct. And he was a National Guard, and we got the actual referral from the National Guard.
I think General Butterworth knows Mike. Do you know Mike?
Yes, sir.
He's a great American hero. He's almost as good as Vondell Brown.
Amen.
He's terrific. You're still willing to do that, correct?
Absolutely.
And I hope this opportunity that's come about for you to serve on an advisory board will give you all a way to communicate, because I have personally seen the miracles Shepherd has performed out there. It's just unbelievable. And the types of, in fact, I'll tell you all an interesting story about Shepherd. I hate to be a homer here, but I'm going to be there for a second. When we went into Baghdad, Saddam Hussein's leading officer was a guy named Captain Farhat. Captain Farhat realized that the Iraqi army was doing the wrong thing, that Saddam Hussein was going to use some bad types of weapons. So he turned on Saddam Hussein and joined the United States Army and fought against Hussein in the takeover of Baghdad. And you tell me when I get this story wrong, but I think I'm right so far. He was captured by Hussein's soldiers and shot 28 times in the back, trying to kill him. They didn't kill him, but they severed his spine, and he was totally paralyzed from the waist down. He was in a United States military hospital. They were trying to save him. The Shepherd Center heard the story and asked me to call the Secretary of Defense, who was Rumsfeld at the time, and said they would treat Captain Farhat's unique injuries if they could only get him to the United States. But it took an executive order because we don't treat foreign soldiers, and Farhat was technically an Iraqi soldier. We got a waiver from General Rumsfeld, or from Commander Rumsfeld, flew Captain Farhat here. He is now married, living in Decatur, Georgia, and self-sustaining himself, even with his paralysis. Is that not right? That's an amazing, amazing story. I just wanted to share that if I could. Sergeant Brown, as you and I were saying, NCOs really run the military, don't they?
That is correct.
The general's over there grinning. He knows that's really true. I was a staff sergeant, too, so we staff sergeant. You're a master sergeant, right? Chief?
That's correct, sir.
Okay, well, you're a little higher than me, but we sergeants still ran things. You know, your testimony is going to be replicated within the VA. I'm going to see to it that you've provided this hearing a tremendous service today. Is there anything you heard from the VA that you'd like to point out, you'd like for us to address in the testimony you heard from the first panel?
Sir, I thank you for giving me the opportunity to speak. I've heard several times about an advisory board. I would really like to know more about that. Specifically, are there any veterans on this board, and what's the intent of this board?
You got them talking back there, so I think that's getting ready to happen.
And also, I commend Director Wiggins. As I think that she has done an exceptional job with coming up with policies and procedures. However, I will say that although they're being written at the higher level, there needs to be much more oversight at the lower level where they're supposed to be implemented. And I don't. You know, it's not hard, but I am just truly honored that I get to sit here and stand in the gap for my brothers and sisters in arms. And one thing that I've been wanting to say is that, you know, the bottom line is we sit here and we can do policies and procedures and we can talk about what's right and what's wrong, but I think for simple veterans like myself, you know, we really don't care how much you know until we know how much you care. And so I would just ask that if we build relationships first, a lot of this would probably be a lot more easier.
I think that's exactly right. You have represented the veterans of America well. You've made a great contribution to this country in serving, and a great contribution to this panel and sharing your ideas. Thank you very much for that.
Thank you for having me, sir.
And I think you're going to get asked to be on an advisory committee. Because when you said that, they were talking to each other, and I don't think they were talking about who won the Braves game last night, although we did win last night. General Butterworth,
Sir.
I'm going to bring up a sensitive subject. I mentioned in my opening remarks, we're finally dealing with the issue of military sexual trauma in the United States Senate and with the DOD authorization. We're learning some unbelievably alarming numbers in terms of the incidence of sexual abuse or sexual assault, as well as its tremendous contribution to mental health issues because of the environment in which it's, first of all, executed, and second of all, there being no real outlet for that person to report it in a safe way or feels like they can't report it in a safe way. And we know it has contributed to a number of suicides for veterans who've come home from active duty. And I know the blended unit of the Guard down at Warner Robins a few years ago had a major incidence with suicide. Is the Guard still experiencing some of the same problems?
The easy answer to that question is yes, sir, unfortunately. I'd be happy to expound on at what length, but the answer is yes.
Well, I was in your testimony, I was struck by the number of partnerships that you formed with outside professionals, if you would, or institutional professionals to deal with the trauma of suicide. It seems like you have reached out to bring private organizations in to partner with you, or in some cases state agencies. Is that true?
Yes, sir. That's very true. And to add to that comment, they have reached out to us, quite frankly. There are numerous examples that I could give you of individuals like those sitting on the other end of the table who have reached out to us and said, if you have need, we have resources. And it doesn't matter at what level the finances will come in, we're here to help veterans. And like I alluded to in my comments, I think that's one of the benefits of the National Guard itself. We're 54 different organizations, each aligned with a state or a territory, and we work directly with the governor, with the governor's staff, with our communities, with emergency management agencies, and for that reason, we have relationships, and we maintain those relationships, which are critical to providing this care.
Well, the comment I wanted to make is when I read your testimony the other night, and then when I heard you deliver it today, following having listened to the VA talk about their issues and us deal with some of the questions of communication, it is obvious to me you've reached outside the Georgia National Guard to bring in partners to help you deal with the problems you're confronting in terms of mental health and mental health recognition, mental health sensitivity, and as Vondell said, what to do. And I commend you on doing that. And I hope the VA will heard what he said and heard what he's doing, because I think with people like Shepherd, Peachford, Wellstar, and a lot of institutions in our metropolitan area, there is help's not on the way, it's next door. But you got to be able to invite them in.
That's right.
And they got to feel welcome to do that.
Yes, sir.
Mr. Brashear, you said something that really struck me profoundly. And if I can read my handwriting. You said that you, in the 3 steps process in terms of dealing with those at risk for suicide, you talked about training the mental health provider, but you talked about teaching the patient what to do. And I think what you were, if they realized they were at risk, if they were having suicidal thoughts, you teach them how to deal with those thoughts to alleviate them. Is that correct?
Yes, and this all came about from the Columbia Research Group, Barbara Stanley and Greg Brown. Basically what they do is they provide a step-by-step process that's preventative in nature. So the first step of that is to identify, to help the patient, help the veteran, help the client understand the circumstances under which they might be gravitating or escalating towards a crisis situation. So it's preventative at the ground level, which is what kinds of thoughts, what kinds of behaviors were you engaging in prior to the escalation of the crisis? Were there, for an individual who may have PTSD, were there certain images, were there certain kind of provocations in your environment that caused the escalation? That's the best time to begin the intervention. Not when the crisis has already escalated. When people escalate, generally their ability to think very logically and rationally oftentimes kind of shuts down. That's what the brain does. And so the first step is collaborating with the individual, helping them understand the circumstances under which they're becoming more at risk. Step 2 is to give them very practical strategies. When you notice these thoughts, when you notice these feelings, when you notice that you're engaging in these types of behaviors, let's talk about a couple of things that you can do to eliminate the crisis. Now, here's a good reason why it has to be collaborative. Somebody says, well, I could turn on the TV and kind of wind down to my favorite show. Say, that's great. What do you think the likelihood is that you would actually do that? Well, not very good. My power got cut off a couple weeks ago. Well, that's a great opportunity there to, again, customize the plan to ensure that these are pragmatic strategies that a person's actually going to follow. If step 1 doesn't work, you go to step 2. Step 2 is identifying certain environments that you could go to just be around other people. That might sound simplistic, but what we know from Thomas Joyner's research is that being around other people actually does help to mitigate the crisis. So we teach people, here's a couple of places that you can go just to be around non-judgmental, non-critical types of people. Step 3, then, if step 2 fails, you go to step 3, 3 to 4, and so on.
Which the light bulb just went off when you talked about I can't go home and watch my favorite show because my electricity's been turned off. One of those comorbidities in terms of suicide probably is homelessness, where somebody doesn't have a place to go to exercise what you taught them to do. Is that correct?
Absolutely.
And we've got a new homeless facility, 40 beds, is that right, at Fort Mac?
Yes, sir.
Is that correct? We're working on that part. But that's excellent testimony. And I think one of the things the military needs to understand, and I think there's an awareness, by its very nature, it is not institutionally a place where somebody with a problem like that would find help. Because institutionally, you take orders, or you give orders, or you're within a close order drill, or you have a AFC, that was what they called it in the Air Force, designation. That was your job, and that's what you did. And there really wasn't an outlet to be able to say, hey, I was sexually harassed, or I'm having suicidal thoughts, and it wasn't kind of a mechanism to do that. And I think what you're doing, General Butterworth, with the Georgia Guard and this recognition program, working the behavioral health people, is teaching folks to identify those things early, so they can get to people like Dr. Bashir and learn, what should I do when I have that thought? And then if we can do a better job to make sure that those in the most trouble, those that are drug addicted or those that are homeless, that we have programs to try and alleviate that comorbidity problem, we can go a long way towards helping to reduce the number of these suicides. Your testimony today from all of you has been extremely helpful, and I think we have all learned a lot. I know I've learned a lot. I want to thank all of you for being here. I want to thank Dr. Petzel and the members of the VA for coming. I want to particularly thank Ryan Evans. Where is it? Ryan, are you behind me? Stand up, Ryan. Keep standing. Ryan Evans has been the leader of this program for about 120 days. She has put it together. She's followed every detail and made it happen, and I appreciate it. Lauren Culberson and Marie Gordon have done the press, and I want to thank them. I want to thank the staff members of the Veterans Committee in Washington, and in particular Chairman Sanders and Ranking Member Burr for facilitating this meeting, and in particular Georgia State University for providing the facility, the security, and everything that we've had today. They've done a great job. I have learned a lot. Hopefully the people of Georgia will learn a lot, and hopefully these ideas shared will not be ideas put away, but they'll be ideas that will be executed within the Veterans Administration to improve the care that our veterans at risk to themselves or with mental health difficulties are having. It's been a great hearing. You've been a great audience. Thank you for being here. God bless the United States of America.